Good evening to everyone and welcome to today's session. With a short delay, we are starting today. I hope you all have answered the questions which we have raised as a poll on the Edmodo. We welcome our online students, Dr. Amrita, etc., etc. Now, there's one last topic left in endocrinology, following which we've opened the chapter of the neurology. In today's discussion, we have totally 4 topics to review. We also invite our online students, Dr. Deva, etc. Now, testicular feminization syndrome. Any entrance you go, either gynecology or endocrinology or pathology or pediatrics, this is going to be one important common topic. You need to know that it is 46XY is the typical genotype in the people who have testicular feminization syndrome. Though genotypically they are XY, phenotypically they will show female external genitalia and often raised as girls. Now, what is the main problem in them? Being XY, obviously they have a testis and they produce testosterone. But there is a receptor level resistance against the action of this testosterone, and if the testosterone cannot act, what will happen? The Wolffian duct and the genital tissues which are responsible for the male external genitalia, they do not respond. That's the reason there is a female differentiation of the external genitalia, and hence external genitalia looks like female. Now you may ask a question. Normally female genitalia in a male XY karyotype, why in why the male, female external genitalia, why they don't develop if they have XY? Because if there is a XY karyotype, generally they will have Mullerian duct inhibiting factor. So that's the reason the Mullerian inhibiting factor prevents the development of the female internal genitalia. If there is a XY karyotype, there is a Mullerian duct inhibiting factor. Because of that, the internal genitalia, fallopian tubes, uterus and upper vagina, they do not develop. So, whereas testosterone is not acting, so that is the reason the Wolffian duct derivatives are not developing. So that is the reason their external genitalia, which are expected to show the male features, they typically will show the female features, and the internal genitalia of the female do not develop. So ultimately what do they have, doctor? They have a testis which has not descended. Why it has not descended and why it is remaining intra-abdominal? Because even for the descent of the testis, testosterone should act on the receptors. Since testosterone is unable to act on the receptors, testis doesn't descend and it remains intra-abdominal. Because of the XY karyotype, there is a Mullerian inhibiting factor. Their female internal genitalia do not develop like fallopian tubes or ovaries or anything, and because the testosterone is not acting and the Wolffian duct derivatives are unable to develop, they don't show the male external genitalia, and ultimately what they show is a blind ending pouch like vagina is the only thing that is left over for them as the external genitalia. Now, what are the important clinical features? They have a vagina that ends in a blind pouch with the hypoplastic male ducts instead of fallopian tubes and uterus. You know why fallopian tubes and uterus did not develop in them? Because of the Mullerian inhibiting factor. And the testis is located in the abdomen or inguinal canal, and it has not yet descended, but they will show the development of the breast. Why, doctor? Because they have a testis. Testosterone is producing, the testis is producing testosterone. but it is unable to act on receptors. So what will the testosterone will undergo? It will undergo a peripheral aromatization into estrogen. Anybody, male or female, who has high estrogen will develop breast. Why there is a breast development in the patients of cirrhosis of the liver, doctor? Patients of the cirrhosis of the liver have a breast development because normally estrogen is metabolized by the liver. If there is a cirrhosis of the liver, there is no metabolism of the estrogen. So that is the reason estrogen levels increase and that lead to development of the breast even in the case of the males with gynecomastia. So there is a reason, doctor, since their testosterone which is produced peripherally aromatizes to estrogen, typically they show the breast development. Since they don't have male external genitalia and what they have is only a blind ending pouch like vagina, they will be raised as girls. Then when will the problem come? Typically they develop the breast, thelarche is there, but menarche is not there. Why menarche is not there? For the menarche to occur, what is needed? You require a ovary, you require uterus. All those apparatus is not available in them because being an XY karyotype, their Mullerian inhibiting factor has inhibited the growth of all those internal female genitalia, female organs. So there is a reason menarche fails to occur. And when clinically examined, you will discover that undescended testis like an inguinal hernial mass. So this is a classical example of a testicular feminization syndrome where it is a blind ending vagina. As a pouch it will end is what you have to basically remember. And what they have is a blind ending vagina with well developed breasts is the classical appearance of testicular feminization syndrome. Now how do you want to treat? That undescended testis anytime can undergo a malignant transformation which is very dangerous. That's the reason you need to do orchidectomy and remove it. Then you need to give estrogen treatment to them and raise them as the girls. So that's what you need to fundamentally do, and surgically you need to reconstruct the vagina for them to enjoy the reproductive, the sexual life is what need to be understood. So that brings us to the end of our last topic in endocrinology, which would be testicular feminization syndrome, on which a lot of questions come. The next topic, a very, very important topic, most commonly asked topic in the entrance, is the meningitis in neurology. Now, what is meningitis? So we welcome our online students Vikas, Fahima, etc., who all have finished their polling in the edmodo.com and ready to face the quiz down the line. So the job is every day one quiz, 5 to 6 topics, high yield topics, and every week around 30-40 high yield topics. Within no time, within about 28-29 weeks of our program, you will be finishing around 1000 to 1200 very, very high yield topics. And 240 marks in NEET PG is going to come from these 1200 topics. You need to have a hold on the topic, on all aspects of the topic, and some tricky things which can become MCQs in the topic, gold medal points in the topic. Everything in the high yield topics you need to have the hold. That is the purpose of preparation. Now meningitis, it is that inflammation involving the arachnoid layer of the meninges, and broadly we divide it into bacterial and aseptic. In both the forms of the meningitis there is fever, headache and stiff neck. So this is a typical gross appearance in the case of the meningitis, where you have a thick exudate in bacterial meningitis, especially if you take the tubercular meningitis, this kind of basal part of the brain where the cranial nerves are exiting, that is the place where you have this thick inflammatory exudate. Now, if you look at etiology, lot of times questions in entrance, in MD entrance come on the etiology. E. coli, Streptococcus agalactici, most frequent organisms in infants. Haemophilus influenza, predominantly seen in the 2 months to 6 years. But nowadays every baby who is being born is receiving Hib vaccine, pneumococcal vaccine. That's the reason the prevalence of H. influenza meningitis has come down. Then Neisseria meningitidis is very common in adolescents and young adults, and the adults more than 25 years, it is the Streptococcus pneumoniae which is the most common cause. Any entrance you write, one question on etiology, etiological factor depending on the age in meningitis is a very important issue. Now doctor, Listeria monocytogenes, elderly people who are immunocompromised, those who are having internal malignancy, Listeria is an organism that you suspect. And whenever it is due to the virus, you call it as aseptic meningitis. Aseptic meningitis and partially treated bacterial meningitis will have more or less similar findings on CSF. Even drug hypersensitivity will also produce a similar picture, like aseptic meningitis is what we need to fundamentally appreciate. Now this one more example of that basal exudate, thick sheet of basal exudate in the case of the meningitis. Now what are the classical clinical features? One patient of meningitis, if you see in the pediatrics ward, you will never forget the entire story described in Harrison or any book. So fever, nuchal rigidity, altered mental status is classical of meningitis. And the source of meningitis in case of H. influenza is from the otitis. Streptococcus pneumoniae is from an underlying pneumonia. Even they also may be coexistent. If it is Neisseria, you know, it is known to lead to development of Waterhouse-Friderichsen kind of adrenal suppression with petechial hemorrhages and gram-negative sepsis. So there are all the features which can occur with Neisseria meningitidis. Then ecovirus, Coxsackie virus, when they cause aseptic meningitis, there can be an associated rash which resembles the rubella, is a very, very classical feature. Now this is one table, doctor, you must be 100% sure. As a house surgeon, how many of you have done lumbar punctures? At least half a dozen lumbar punctures. Without doing lumbar puncture, you finish housemanship means the lumbar puncture needle will feel insulted. Array, this doctor did not break me at least once, she will feel. So that's the reason, she or he, depending on the needle. Now, what are the typical CSF changes? In the case of normal person, CSF is crystal clear, mononuclear cells are less than 5, there will be no polymorphonuclear leukocytes, protein will be 0.2 to 0.4 and glucose in the CSF will be between 2/3 to 1/2 that of the blood glucose. These are typical normal CSF. That's the reason normal CSF should always be interpreted in relationship with the normal CSF glucose in relation to the blood glucose. Whereas in viral, there will be 10 to 100 per millimeter cube mononuclear cells and there is 0.4 to 0.8 grams per liter of protein and greater than half that of the blood glucose is a classical feature. Whereas in pyogenic meningitis, if you look at the blood glucose, it will be less than half that of the blood glucose. So low glucose in CSF is an important feature in pyogenic meningitis is what I want to underscore to all of you. That's what is called as hypoglycorrhea. Then mononuclear cells typically will be less than 50 in pyogenic and PMNs will be 200 to 300. Whereas if you look at the TBM, the mononuclear cells like lymphocytes, they will be very rich, 100 to 300 per millimeter cube. And just like pyogenic, even TBM also will lead to hypoglycorrhea, is what you are going to ultimately remember. Then this is another table which you need to remember for the tomorrow's exam. Children and young adults, Neisseria. Neonates, group B streptococcus. Adults, H influenza. And all ages, gram-negative rods are possible, is what you have to fundamentally appreciate. Now, how do you treat the bacterial meningitis? Most of the drugs are blocked by the blood-brain barrier. So, that is the reason you need to give the maximum tolerated systemic dose and you need to give for a duration of total of 2 weeks. That is considered with the protocol. If it is an adult, what is the empirical treatment? We give a broad spectrum cephalosporin and a vancomycin. If you are suspecting listeria, you need to add ampicillin. So this is another classical example of the turbid nature of the CSF in case of the bacterial meningitis, as what you can see. Now, Streptococcus pneumoniae can be resistant to penicillin and sometimes cephalosporins, and such kind of resistant strains are frequently isolated. And whenever there is a pneumococcal meningitis, you should not forget to add the vancomycin to the regime, and you also need to include a short course of corticosteroids if there is a pneumococcal meningitis. Why corticosteroids in case of pneumococcal meningitis, doctor? Because pneumococcal meningitis forms thick exudate. That exudate will cause the cranial nerves in the base of the brain to get sequestered in that exudate, and that can lead to development of cranial nerve palsies, loss of hearing. So many problems will come unless you add steroids. So that's the reason pneumococcal meningitis with thick exudates, the very important rule is to add the steroid in addition to the antibiotics is what need to be remembered. Tell me one more situation where you want to add steroids. Tubercular meningitis, you need to add steroids as a part of the treatment. Now, what are the empirical antibiotic of choice? If it is meningococcus benzyl penicillin, pneumococcus cefotaxime, Haemophilus cefotaxime, unknown pyogenic also cefotaxime is the part of the empirical management. So, this is in summary about meningitis. How is the CSF? What are the organisms? How do you treat empirically? These are the issues frequently asked, and TBM versus bacterial meningitis, you must know the differences, which is very, very, very important. Now, the next important topic would be the epilepsy. Now, let us take up this very important topic, and after this topic we will take up the quiz. Now, a basic fundamental question asked by the professor of medicine in the ward rounds is define seizure. So, what will you tell, doctor? Synchronous discharge of the neurons is the normal nature, but if there is a large group of neurons activated repeatedly, unrestrictedly and hypersynchronously, then there is a failure of the synaptic inhibition and that lead to the seizure. And seizure is that paroxysmal electrical discharge of the cerebral neurons, as all of you know. Then what is epilepsy? Epilepsy is basically that continuing tendency to have seizures, which is basically a disease. And the most common type is generalized tonic-clonic seizure is what need to be remembered. Now, on the EEG, What is a very important hallmark of seizure? A high voltage spikes and waves are the classical electrical activity. Now, what is a partial seizure? If there is an epileptic activity which is confined to only one area of the cortex with a recognizable clinical pattern like Jacksonian march, then you call it as partial. Jacksonian march is a simple partial seizure basically. So, this seizure can remain focal, which has started focally, or secondarily it can get generalized. So, whenever you see a generalized tonic-clonic seizure, what are the two possibilities? Either it can be primarily only generalized seizure, or it may be focal initially and later on it became secondarily generalized. Just like in first year MBBS, few people are focal. By the time they go to final year, they become elaborate and the best guys in the class. Some guys may be from the first year anatomy only the best guys. We can't help it. They are all primarily generalized. Now, what's the mechanism? What's the mechanism of the seizures? Since seizure is a electrical activity focally, it can lead to development of aura. Suppose if one important area where aura is produced, their electrical activity is produced like in temporal lobe, then that can lead to development of the aura. So, aura is that stereotyped perception which is caused by the focal electrical activity before a partial seizure, and patients will feel some like a rubber tire burning kind of a smell, tingling in one limb, strange recognizable inner feelings. They are all the aura which can develop in them. So, is there any way by which you can differentiate whether the seizure is secondarily generalized or primarily generalized? Definitely. If there are aura means, it is a clue to say that it is a focal seizure which later on got secondarily generalized. So, aura is a way to recognize. In case of primarily generalized tonic-clonic seizures, there will be no aura. So, aura is a way to differentiate whether a focal seizure later on got secondarily generalized or primarily only is it a generalized seizure. So, International League Against Epilepsy has broadly divided the seizures. You have generalized seizure types which include absent seizures and generalized tonic-clonic seizures. Once more, absent seizures are divided into typical absent seizures where you have 3 Hz spike and wave discharge, which is called petit mal epilepsy. Atypical absences with other EEG patterns. So, that is how you broadly classify the generalized seizure types. Then the other generalized forms are myoclonic seizures, tonic seizures, kinetic seizures. Then you have partial seizure types. They start with one focal activation of the neurons. So, you have simple partial means there is no loss of consciousness. Then you have complex partial where there is loss of consciousness. So, simple partial seizures without impaired awareness and consciousness typically present like Jacksonian march, little twitching in the fingers, then slowly the seizure activity will be passing up. So, that is a typical feature which you see. Then you have a complex partial seizure where there is an impaired awareness. Then you can have partial seizures which ultimately evolve into tonic-clonic seizures with secondary generalization. So, this is how you divide the partial seizures into the various varieties. Then ultimately you have unclassifiable seizures, the seizures which do not fit into any of these categories. So, doctor, you need to know that absent seizures are an example of a generalized seizure type, whereas complex partial seizures are an example of a partial seizure. Why you often get confused? Between which kind of seizures do we get confused? We often get confused between absent seizures and complex partial seizures. Why? Complex partial seizures are partial seizures with a loss of consciousness. Absent seizures are the generalized seizures with a transient loss of consciousness. So often there is a confusion between complex partial seizures versus absent seizures. Now, doctor, what is the meaning of generalized? Generalized means to say that there is a bilateral abnormal electrical activity, bilateral motor manifestations with the impairment of the consciousness, which is a very, very important feature. Then, as we already said, simple partial seizures are associated with Jacksonian march, with one limb jerking is what you classically come across. Now, what are typical absent seizures? They are also called petit mal epilepsy. They invariably begin in the childhood. Quite often, the teacher will be thinking, one of the pupil who is sitting in the classroom, that he is an inattentive child, because he had been staring towards the teacher as such. The looks will be penetrating through the teacher instead of towards the teacher. So teacher will think, why this fellow is watching at me like that instead of studying what I told him. And the teacher may say inattentive pupil, but actually the child had absent seizure. But that absent seizure comes like a spell. Abrupt onset, abrupt offset. And the child will not be aware that it happened to him. Otherwise the child would have told the teacher that, teacher, you are not really that beautiful for me to see. I am having absent seizure, the child himself can say, but child will not have awareness. So that is abrupt onset, abrupt offset with a spell of loss of consciousness without memory of what happened. That is the typical example of what is called absent seizure. Typical means there will be 3 Hz spike and wave pattern. The child will have staring and paling for a few seconds, and after the seizure the child will resume the normal activity. And this is a classical example, 3 Hz spike and wave activity on EEG, classical in the case of the absent seizure. Now, typical absence attacks, they are never due to any acquired lesion like tumor, and basically they are a developmental abnormality on the neuronal control of the electrical activity. So that is the reason by the time the individual grows to 20-year-old, the absent seizures which started in childhood will also stop coming. So that is a very important good point about absent seizures. Few of them who had absent seizures in childhood may end up in generalized tonic-clonic seizures at a later point of their life, but most of them will be able to overcome it by the time they come to their second decade. And if you look at the petit mal, when do we use the word petit mal? Petit mal are those 3 Hz absent seizures, only those 3 Hz spike and wave absent seizures. Suppose if temporal lobe is involved and the person loses consciousness, then you don't call it as absence. So that's what, then that is not called petit mal. You must be very, very sure about. So you need to differentiate complex partial seizures with loss of consciousness versus absent seizures. Now, generalized tonic-clonic seizures is the next important variety. In this, the person becomes rigid for up to a minute, and he will fall down. Sometimes they suffer serious injury. The tongue is bitten. There is an incontinence of urine. There is a frothing across the mouth, bilateral rhythmic jerking, and usually they are all self-limited, GDCS. and after the seizure, generalized tonic-clonic seizure, patient will develop post-ictal confusion, drowsiness or even coma for several hours is what need to be basically remembered. Then comes the myoclonic, tonic and echinatic seizures. Myoclonic means sudden jerking. The child will be on the breakfast table and suddenly he will have those salam spells. Is a very, very important feature. Then in that there is one variety where myoclonic seizures will start in the adolescence, which is basically called as juvenile myoclonic epilepsy. Then we have tonic seizures, means there is an intense stiffening of the body but not followed by jerking as in tonic-clonic. Then echinatic means sudden cessation of the movement and falling and loss of consciousness. They are all the important different types of generalized seizures. Then in partial seizures we have simple partial where there is a Jacksonian march, and partial often originate, simple partial originate directly from the motor cortex. And typically the jerking will be seen on one side of the mouth or in one hand, and sometimes it will spread to the entire side, is basically the Jacksonian jerking of simple partial seizures. Suppose if this electrical activity is coming from the motor cortex in the frontal lobe, then the child will develop a conjugate gaze of the eyes. Why? Because the control center for the ocular movements is located in the frontal lobe. So typically the child will have a conjugate gaze where he deviates away from the epileptic focus, is what you typically come across. There can be a local temporary paralysis of the limbs which are affected, which is called torch palsy, which can also occur in case of the seizures. Then sometimes seizures can originate from the temporal lobe, is what we need to remember. Then about torch palsy, in our earlier slide I forgot to tell you, torch palsy and aura, what are they indicative of? They both are indicative of the partial and the focal nature of the seizure. So if there is a generalized tonic-clonic seizure, if the aura is there or if torch palsy is there, that always points that what kind of seizure it is? It is a primarily focal seizure which later on secondarily generalized. The presence of the aura and the presence of the torch palsy is what you have to basically remember. Now we have temporal lobe seizures. Patient can get a feeling of unreality, jamaisu, undue familiarity, like déjà vu. So while answering the MCQs in the entrance, suddenly after looking at a new question we feel, yeah, I know that. You may not really know that. It is just an undue familiarity, déjà vu, that you are suffering in the exam hall. So that is the reason question should never give you déjà vu in the tomorrow's exam. Be very, very sure about it, doctor. There can be blank episodes of staring, vertigo, visual hallucinations, especially when they are originating from temporal lobe. And there are some peculiar presentations of the partial seizures. There are peculiar presentations of the partial seizures. Patient can have panic attacks, hyperventilation, especially when temporal lobe got involved. There can be sense of strange smells if it is a frontal lobe. There can be sensory disturbances if it is a parietal lobe. There can be crude visual shapes which can be appearing if it is an occipital lobe, is what you have to ultimately remember. So now, doctor, what is the etiology of the epilepsy? There can be genetic predisposition, there can be certain structural abnormalities like hematomas, etc., etc. And there can be any intracranial mass lesion like cerebral infarction or arteriovenous malformations. Then there can be metabolic abnormalities like porphyrias and hypocalcemia responsible. And there can be certain drugs, one of the favorite question of the examiner, drug-induced seizures. lidocaine, quinolone, cyclosporin, SSRIs, interferons, cocaine, lithium, amphetamine withdrawal, barbiturates, any of them can lead to the development of the seizures. And alcohol withdrawal, you should not forget. Your patient who is a farmer in the village, who is admitted under you, suddenly developed seizures. So what is the underlying cause? Farmer means what do they do in village, doctor? They are very happy people. Nicely evening 6:30, 7 o'clock, wife will prepare hot chicken and they will get a nice toddy. They eat chicken nice toddy and then happily enjoy the moonlight under the hut with the wife and live. But that poor farmer who was living every day with a nice food and nice drink ultimately has got some malaria, which is also common in the farmers, and had been admitted under you. 3 days he is hospitalized. What he is missing? He is missing his wife's love, the moonlight, and a beautiful toddy and alcohol. And he develops these seizures. What are they called as? Rum fits. They are generally self-limiting. Nothing need to be done. They are quite self-limiting in nature. So the treatment is not pouring alcohol into the rice tube. So don't do that. Now, porphyrias, hypocalcemia, they are the other important things which need to be remembered. Now, a very important surgically treatable cause of seizures, epilepsy, is the hippocampal sclerosis. Some people in the medial temporal lobe area typically have got a sclerosis which can be the focus of the seizures, which is surgically treatable. And if you look at epilepsy, a common question asked is, my cousin has epilepsy, doctor, what is the chance of my getting epilepsy? 30% of epilepsy patients have first degree relatives. Any patient who has a hydrocephalus also, his seizure threshold will come down. Epilepsy is more common in the patients who are having multiple sclerosis. Now this is what exactly I am saying. Typical MR, where you are able to see the sclerotic focus, the MRI of the brain. Once more, in the weighted image, you can be able to see the typical area of the sclerosis. This medial part of the temporal lobe sclerosis is one of the important surgically treatable causes of the epilepsy, is what need to be remembered. Then MAO inhibitors, phenothiazines, tricyclic antidepressants, SSRIs, amphetamines and propofol, which you should not forget in the anesthetics, and nalidixic acid. They can sometimes provoke the fits. Then withdrawal from the phenobarbital or benzodiazepines can also be responsible for the development of the seizures. Then which electrolyte abnormalities patients can develop seizures? It is not uncommon that a patient who is hyponatremic, if there is a hyponatremia, what will happen, doctor? The plasma osmolality is very low. So that is the reason all the water will be dragged from the plasma into the brain, and the brain cells are all swollen, and that lead to drowsiness, and if severe hyponatremia is there, patient can go into seizures. So hypocalcemia, hypoglycemia, very common cause of seizures. Whenever you walk into casualty, somebody is having seizure activity, what will you tell? Sister midazolam. In addition, you should also say sister glucose. So parallelly, you should also think of hypoglycemia to be an underlying cause. And Sister Mary will check the glucose. Glucose is 40 only, doctor. Then you run 25% dextrose, seizures will stop. That's the reason all seizures, you need not think of giving phenytoin drip. Seizures in inpatients can even be due to hypoglycemia also. That you need to basically treat and cure. So uremia, hepatocellular failure, mitochondrial disease, porphyrias, they are all the ones which are responsible. Few people can have photosensitivity seizures as a provoking factor. Then febrile seizures, high pyrexia can be a predisposing factor, especially the children under the 5 years of age, they will have febrile convulsions. And most of the times, there will be no recurrence. There is no need of a long-term anti-epileptic treatment for febrile seizures. But that upper age limit you should not forget. After 5 years, you will not think of febrile seizures. Febrile seizures are a diagnosis you will think. Below the age of 5 years is what you have to basically remember. Then missing the sleep, deprivation of the sleep can be one of the important predisposing factors for the development of the seizures. So how do you diagnose? EEG is the central theme in the diagnosis of the epilepsy, is what you have to basically remember. So there can be focal cortical spikes if it is originating from temporal lobe, or there can be generalized spike and wave activity, 3 Hz spike and wave activity. Now, suppose if the interictal period may EEG is normal, does it exclude the epilepsy, doctor? No. Many people who have epilepsy in the interictal period, if you do the EEG, it may be absolutely normal. Then there is one more caveat which you need to know. In the interictal period, if there is a abnormal EEG, even that does not prove that there is epilepsy. So this is also the caveat, clinical caveat which you need to know. Now, how do you manage in emergency a patient of epilepsy is my question to all of you. If it is a prolonged seizure, longer than 3 minutes, or if it is a repeated seizure, then you need to treat with rectal or IV diazepam or midazolam. If you suspect hypoglycemia, treat the hypoglycemia. Then status epilepticus is a very, very important entity. So, if there is a continuous seizure without any recovery of consciousness in spite of 30 minutes of ictal activity, 30 minutes of ictal activity, then you call it as status. The mortality is between 10 to 15%, and all status need not show that convulsive activity. Suppose petit mal epilepsy is showing status, then you can have non-convulsive status is possibility. Then epilepsia partialis continua is that continuous seizure activity in one part of the body like the finger or limb without the loss of consciousness. Generally, epilepsia partialis continua is due to the cortical neoplasm, and in the elderly people because of an infarct in the cortex. So how do you manage status epilepticus? We give immediate diazepam 10 to 20 milligram IV at 5 milligram per minute and repeat once. If IV access is impossible, then you can give rectal diazepam or peraldehyde, and always remember of hypoglycemia, and you need to supplement thiamine, especially if the underlying person is having a alcohol history. Then you need to give lorazepam intravenously 4 milligram at 2 mg per minute. You need to ask previously, is he receiving any anti-epileptic drugs, because one of the most common cause, what is the most common cause of the status epilepticus? It is non-compliance to the drugs. Previously patient was taking drugs, one fine moment he thought, what is this, every day taking this drug, and for about 3-4 days he stopped taking drugs and he may end up in status epilepticus. So non-compliance to the anti-epileptic drugs is the most common cause for the predisposition to the status epilepticus. Then if the status continues, we need to give IV phenytoin or fast phenytoin. And phenytoin, how do we give? 15 mg per kg, IV diluted to 10 mg per ml in 0.9% saline. You need to give it in a large vein at less than 50 mg per minute infusion rate. Then fast phenytoin is a prodrug of phenytoin. It has got a much faster activity than that of the phenytoin, and we express the phosphenytoin in the form of phenytoin equivalents. We express phosphenytoin 1.5 mg is equal to 1 mg of phenytoin basically. Then what is the difference between phenytoin and phosphenytoin? If a dextrose containing drip, if you add phenytoin, it will undergo the crystallization. Whereas phosphenytoin can be comfortably added to any fluid. Whereas phenytoin can only be added to saline, not to the dextrose containing fluids, is what you have to basically remember. Then if the status is continuing in spite of phenytoin, phosphenytoin, then phenobarbital. Still status is continuing, then clonazepam, penaldehyde. And if the status is persisting more than 90 minutes, it becomes an indication for once army failed, navy failed, air force need to take over. Who is air force doctor? Anesthetics, propofol or thiopental anesthesia with an assisted ventilation and intubate the patient. That's what you need to fundamentally do in order to manage the case. Now, for both one of the common questions in the exam is, what is the first line treatment? For both the partial and generalized seizures, monotherapy with an established first line anti-epileptic drug, you need to be very, very sure. Good number of people, one drug is enough. Maximum 2 drugs are required. If more than 2 drugs are required, means possibly patient has got multiple seizure types. That's the only underlying cause. So what is the first line is one of the important questions. In GDCS, first line is carbamazepine, lamotrigine, phenytoin, valproate. And in case of petit mal epilepsy, ethosuximide and valproate. And one important point you need to remember is if you give phenytoin or carbamazepine by chance in a petit mal epilepsy, instead of helping patient, that can worsen the attacks. Similarly, carbamazepine and phenytoin, you should remember, never give it if it is myoclonic seizure. If you give it, it can in fact worsen the attacks, is what you have to basically remember. Once more, valproate, clonazepam and lamotrigine are the best drugs in myoclonic seizures. For the atypical absences, we give lamotrigine, clonazepam and valproate. And always the rule in anti-epileptics is, just like in antihypertensives, start low, aim high. So you need to start with a dose which is low and increase until the control is achieved. Then the side effects of the various anti-epileptics is another very, very important and favorite question of the examiner. Ataxia, nystagmus, dysarthria, anything can be the problems. And chronic phenytoin usage there is a gum hypertrophy, hypertrichosis, osteomalacia can occur. That is vitamin D deficiency. And folate deficiency and polyneuropathy, encephalopathy, anything can be the problem with chronic phenytoin. And valproate, carbamazepine, phenytoin. You need to be careful because they can lead to severe skin reactions, especially in the first 8 weeks after the treatment. That is, Steven-Johnson syndrome can be one of the important problems that can arise with these 3 drugs. Vigabatrin, we are little worried because vigabatrin can lead to irreversible visual field defects. That's the reason it is no longer advocated. Now one important question comes, epilepsy and gynecology, epilepsy and obstetrics, epilepsy and conception. So, carbamazepine, phenytoin, phenobarbital, you are worried to give in a woman receiving OCPs. Why? Because they can induce P450 system and that can decrease the efficiency of the OCP and she may become pregnant without her desire. But valproate doesn't interfere with the OCPs. That's what you need to appreciate. Then ideally you should advise, if they are already on anti-epileptics, to take up an alternative method like barrier or IUCD. Now if there is a history of epilepsy, that can be one of the etiological factors for a decreased fertility. And the They can be anovulatory cycles, polycystic disease, irregular menstrual cycles, all are possible, especially in the women who are receiving valproate. Because valproate will lead to weight gain. Increased weight gain will lead to polycystic ovarian disease with glucose intolerance and insulin resistance. So these are all the problems, especially with valproate. And the risk of birth defects will increase, which is another important problem. And you have to continue, let us say, anti-epileptic drugs need to be continued. Then what is the protocol? You need to give folate supplementation, and in the last month of pregnancy you need to give vitamin K injection in the women who are receiving the anti-epileptics, because anti-epileptics can predispose to the neonatal hemorrhage. That's a underlying reason. Then when to withdraw the drugs? This is a $1 million question asked by the patients. Doctor, nowadays we are not having seizures, shall we continue or shall we stop the drugs? At least 2 to 3 years of seizure free period if the patient is in, then you can be able to go for the drug withdrawal. Then any role for neurosurgery? Definitely. Medial temporal lobe sclerosis is surgically treatable. Then very severe form of intractable epilepsy can be treated with non-dominant anterior temporal lobe amputation is one of the surgical ways of the management. Now, some common idiosyncratic reactions of the anti-epileptics which you should not forget in the tomorrow's exam. Phenytoin, rashes, SLE, Steven-Johnson, lymphadenopathy, blood dyscrasias, they are all possible. Carbamazepine can lead to Steven-Johnson, blood dyscrasias and rashes. Valproate can lead to hair loss, liver damage and anorexia. Lamotrigine can cause Steven-Johnson. So these are all the important things that you need to know when it comes to epilepsy. So let me once more reinforce to you, doctor, epilepsy is one topic. If tomorrow is your exam, it's worth revising today, because a good number of times one or the other question on the anti-epileptics is the part and parcel of every entrance exam, NEET PG, State PG, USMLE, any exam that you take. 2 minutes will be out of video and to take a backup, and then we will continue.